Infective endocarditis is an infection of the endocardial surface of the heart, which is the inner lining of the heart that sits on top of the myocardium. It usually refers to an infection of one or more valves or an intracardiac device, and is usually caused by infectious agents such as bacteria. These organisms colonize on valves, forming vegetations, which are small clumps of material containing bacteria, small blood clots, and other harmful debris that continue to grow and can spread to other surfaces of the endocardium. The valves of the heart don't receive any specific blood supply, which means that the body's defense mechanism, such as the white blood cell response or any drug therapy that can be initiated, will be blunted because it cannot directly access these areas. There are risk factors for infective endocarditis are broken up into two broad categories, which is cardiac risk factors and non-cardiac risk factors. Cardiac risk factors include things such as a history of the disease, presence of a prosthetic valve, or a history of congenital heart failure. However, in our case, Terry's suffering from the biggest non-cardiac risk factor, which is the use of intravenous drugs. There are others, such as intravenous indwelling catheter presence or immunosuppression, but they're not applicable in this case. Intravenous drug use is a high risk factor for two main reasons. Firstly, in the process of drug injection, patients may also inject bacteria or fungus that are present on the surface of the skin or in the drug itself. And secondly, injection of particulate matter, such as talc, along with the illicit drugs, may cause endothelial damage to the tricuspid valve. This may also cross pulmonary capillaries and abrade or damage the endothelium or the mitral or aortic valves. Staphylococcus aureus is the most common cause of infective endocarditis among injectable drug users, and it accounts for more than half of the cases. The other two main types of bacteria are streptococci and enterococci. In addition, intravenous drug users were among the first patients in which MRSA, which is methicillin-resistant Staphylococcus aureus, were observed. So it's important that we take the proper procedures when treating a patient. The clinical manifestations can include a rapidly progressive infection, or it can be a subacute, slow development, low-grade fever and non-specific symptoms. The most common symptom of infective endocarditis is fever, which is attributed to 90% of the cases. It's often associated with chills, anorexia, and weight loss. Some of the symptoms can include headache, night sweats, abdominal pain, dyspnea, cough, and pleuritic pain. And cardiac murmurs will be observed in up to 85% of the patients that we're treating with this disease. It's diagnosed using a combination of clinical manifestations, blood cultures, and echocardiography. So at least 3 sets of blood cultures should be obtained from separate venipuncture sites prior to the administration of any antibiotics. And an echocardiograph should be seen as one of the first clinical diagnostic tools that are used because it clearly shows vegetative growths and it can eliminate or identify other cardiac issues such as valvular dysfunction, whilst also assessing ventricular function. Once all these results are collated, they're applied to a table called a modified Drude criteria. This table will indicate whether it's a definite, possible, or rejected case of infective endocarditis. The goals of treatment are to eradicate the infectious agent and to treat any complications. Antibiotic therapy is used to eradicate the infectious agent, and treatment regimes will vary depending on the different kind of infection. Commonly used antibiotics can be vancomycin, gentamicin, and penicillin, but this is directed by the antibiotic treatment guidelines and your medical officer. There are multiple complications that need treatment and monitoring. Terry has developed sepsis, which is a systemic inflammation due to infection. Up to 25% of patients with infective endocarditis will develop this serious condition due to the high risk of septic emboli being mobilized from the endocardium into systemic circulation. Septic shocks then occurred for Terry. This is where widespread infection in the body has caused a white blood cell response. This response has triggered cytokines to vasodilate blood vessels to slow down blood flow and allow more time for the white blood cells to activate. Whilst this is beneficial on a small scale, on a larger scale all over the body, it causes an extremely low blood pressure and can be life-threatening. This low blood pressure means that organ blood flow is reduced and cellular metabolism can't occur due to low oxygen levels in the organs from the lack of red blood cells that are approaching. Therefore, multi-organ failure can occur. The risk of death from sepsis is as high as 30%, but when patients enter septic shock, it rises to as high as 80%. And it's really important that the identification and treatment of sepsis is timely and accurate. There needs to be rapid with fluid resuscitation and antibiotic therapy, which are the cornerstones of treatment for septic shock. Fluid resuscitation should be in large bolus amounts, and volume status assessment should occur pre and post administration. Sepsis guidelines are specific guidelines for treatment, and they're accessible across any wards throughout the hospital, and it's really important that all staff are trained in their use and are confident in using these tools. Treatment for septic shock requires a really strong peripheral access for both fluid and antibiotic administration. It's also critical that all evaluations and monitoring are exact, timely, and precise. This can require the use of a large range of central venous catheters, particularly in this case, given that Terry is an intravenous drug user, which can lead to veins being easily collapsible and making it very difficult to maintain peripheral access through things such as a cannula site, which can be life-threatening in the case of septic shock.